And I thought we would just take questions if people have them. If no one has questions, I can make up some questions. I'll start with one for all of you guys. Going through medical school, I did a business school and I was in medical school. I always said that part of the reason I did that was because I always saw all the problems in healthcare. That was 25 years ago. And I feel like I still see all those problems. I still am a practicing physician. How do you not get overwhelmed by, if you're an entrepreneur in healthcare trying to work on something meaningful, how do you not get overwhelmed by all the problems, and where do you even start? As a part of running my investment group, I always felt like the best pitches were those that were super well focused, not trying to solve all the world's healthcare problems, because we all know there are a billion of them, but being, very, like, finding a really focused and unique need that you can really wrap some technology around. Do you guys share that perspective? Do you have a different perspective? I'd just like to hear your thoughts.
For radiology and AI, it's all about asking the right question. So I think that's where we really need to work on, is thinking about what question we want to answer, because I think people think about it as a Band-Aid. They're just going to throw AI on everything and it's going to be great, and that's really not how it works. You need a lot of physicians involved, and I think it's up to all of us to educate our patients about what we're doing. I think for anyone doing any innovation, it all just comes down to educating our patients as a good first step.
I'm in the trenches. I'm taking care of my patients. I'm running my practice. I'm kind of, and that really is. So when you're working in it every day, you want to modify or make a change. And I think that's what drives you. And so as crazy as my life is, and I did not expect to be an entrepreneur, I really find that I like to go back to my practice because it grounds me. I talk to my patients every day. I talk to my doctors every day. I hear it all the time, and it just reinforces. So I think that it kind of almost, it's synergistic, but it can be also challenging. But I'm a woman, so it's easy.
Well, I live in a world where, as an employer who's using direct primary care and as a customer, I have zero turnover last year. I had zero turnover the year before. I've never experienced that in 10 years of business. I went for MAs last week, and I just picked the first 4 because they were so outstanding, because they're attracted to a company that offers no copay, no deductible, no premium health care. I mean, who offers that? So the first candidate, we didn't need to continue the interviews because we found everybody. That's the quality we're attracting now. I've never experienced that. So employers are a winner in this future. That's now. Patients are a winner in this future. The doctors are a winner in this future. We're not having stressors right now. It's going away with this new model, really.
Sure. I mean, for me, I think it's a different way of looking at healthcare, right? I think the idea of spending years in medical school and then you graduate and then they put you in a room, in a dark room to wait for sick people to walk in is like mind-boggling, right? Because when you go to medical school, for example, you understand how to stop disease, right? But we don't stop disease. We're doing sick care instead of health care. And so every solution we come up with is how to take a hammer and just hit everything in the head. I think it's completely different. I think that there's a different way we think outside the box and look at healthcare from a completely different perspective. I will hope that when we have discussions like in healthcare and AI, for example, we say, oh, is AI in healthcare? We use AI in healthcare. Facebook is AI, Netflix is AI. They don't talk about AI. Netflix doesn't say I'm an AI company. Google doesn't say I'm an AI company. They're solving a particular problem, right? If we solve a particular problem, we don't need to talk about the technology. I don't need to say blockchain. I don't need to say AI. It's irrelevant, right? It's just solving the real problem. And I think if we have that mindset going forward, then we don't have to discuss if AI is groundbreaking or not. It would actually change healthcare. And I think we're in that position to do it. I think that's why this is the first year this conference is taking place and the room is full. Because we're all fed up. And I liked your talk, for example, right? That energy and the movement to say, hey, let's do something different. We could do it ourselves. We don't need someone from Wall Street to come make this happen, right? And that energy to have us all here, I think should get bigger next year, and I think we can do it.
Thank you. I have to credit my friend and mentor, Dr. Lily Luau, for really challenging me when I went into clerkship to really find, when my frustrations came about was to turn those into opportunities. And so as I went every week or two, I'd write down a challenge that I'd face, and really that is also an opportunity. And now that I have this list of 50 opportunities, it's not about the how, because I can't do it, but it's about the who. And so I've been working and had some success at finding a variety of entrepreneurs where I've told them these are the challenges and tried to set them up with the tools to start spinning out companies. So I think it's approaching our roles as physicians as kind of the ultimate boot camp in terms of needs finding, and then finding the right people to take those ideas further.
I agree. Your thoughts are your reality. So it's either a frustration or it's a challenge. And so I think we as physicians are really good at looking at things as challenges and problems that we need to solve rather than a frustration. So.
I think when it comes to not feeling overwhelmed, I mean, definitely credit of the people with a much more medical experience here on this panel. But there's a doc out of Jefferson University. He's a professor. He's Dr. Bonku. He's an emergency medicine doctor who does a lot of design work. And he actually credits innovation and entrepreneurship and design thinking as a tool to fight burnout for physicians, where we feel in medical school and in our practices that we don't have control. Actually building this, I would probably argue that most of us on this panel feel better, when we come up against a challenge and maybe overcome, even if it's small.
Yeah, one of the advantages to being in healthcare is if you're in the trenches, you actually understand what works and what doesn't, and can see the opportunity. Although, I mean, some people argue for being able to come from other industries, but that's where kind of the synergy comes from, and that's one of the things that Stanford Biodesign does, is they bring together people who don't understand healthcare, people who understand healthcare, bring them together, they get something better than the parts. So, other questions?
Thanks. A question about that direct physician model, and maybe it's an Uber doc perspective as well, but what happens when it's a serious, one of those rare, like, oh, it is cancer, or it is the big thing that's
So
take a lot of
Uber
money?
doc is the first visit. All subsequent care can be between the doctor and the patient. We understand that the most important thing is to get the patient to the correct doctor quickly. In Boston, we have specialists galore. You can trip over them in the streets, but it's a 52-day wait to get into a doctor. My brother is a G1 oncologist at Dana-Farber. To get to him, you need to phone a friend. You have to know somebody, have the right employer, have the right insurance or the right money. That's wrong. Everyone should have access to the best, democratize access to care for a flat fee of $300. It doesn't violate Medicare. It doesn't follow any rules, break any rules, and then subsequent care can be dictated by insurance. That's okay.
Great. I'm glad that you asked her a question, because I want to ask her a question too, which is,
Oh, no.
well, I mean, one of the tenets of primary care, right, is being able to direct the appropriate care. Yeah. So if I'm a Joe Schmo off the street who thinks I need to see some super specialized urologist and I'm willing to pay for it, is that okay? I mean, yeah, I mean, they have time, I'm giving them money, but maybe I'm taking a valuable resource away from someone else who actually really needs that person. So how do you, because primary care and directly booking for a specialized care, that almost to me goes against each other.
So in that lovely Snow White world, yes, your primary care is there, but how many of you know your primary cares anymore? In your own community, it's so hard to find. In my community, it's a revolving door. And we don't even know, and you can't even get to them. There's one primary care, there's a lot of mid-levels. It's very confusing for patients. Oftentimes, I'm the only constant. I'm their specialist. They see me for their venous disease or their breast cancer, and I'm the only person that they see the same face all the time. So I think that when we started this model, it was about working around those obstacles. We now invite our primary care colleagues onto the platform. They're in the same boat as everyone else. Patients need to get to doctors. They need to go to the people who have spent the time, gone to the training, because more experienced individuals will give a better answer. Right now, you've got people going into walk-ins. They're seeing mid-levels. Mid-levels aren't bad people. They're inexperienced. And when we were all interns, we ordered a lot more studies and a lot more tests than we did when we were experienced. And I think that's just, you have to accept that. So yes, we do not expect to, we started this model to kind of make it easy, and this model has now evolved to include all of us, because the issue to access of care and price transparency affects literally everyone.
I think you might have also asked a different question when you talked about who pays for the cancer, if somebody gets that. Was that what you were implying, is who covers that big cost?
Yeah, and I'm an employer too, and
right.
That your model sounded great in certain, for the run-of-the-mill
cardio, collision, cancer. So smaller employers like me have a company called Sedera that handles the catastrophic. Larger employers that self-insure use what's called a stop loss. So they'll, up to a certain ceiling, maybe pay everything over $100,000 as a third party. So none of that risk is on the patient. The patient's not going to have to deal with that. So yes, it's a scary question, but the Snow White world's just signed up the state of Nebraska and the state of Colorado. So it's getting pretty real fast. Did you have something you wanted to say?
No, I agree.
Okay.
I just want to add one thing is that remember we're building healthcare for the future, not the past. Bernie Sanders had a cardiac event, was admitted to the hospital, had a stent, and was home and back on the campaign trail within 2 weeks. In the old days, he would have been in an ICU with his chest opened, 6-week recovery. So what are we worried about that catastrophic event? Your employee who has a terrible cancer, it's unlikely they're going to sit in a cancer center for weeks on end. They're going to get a pill that was made for them through the swab in their mouth, and they're going to take that at home. So the cost of that pill is almost irrelevant because the cost of delivery becomes zero. And I think that's what we have to think about when we build our healthcare costs, is honestly assess what it's going to be for the future, not what it was 20 years ago.
One more question.
Well, I have two questions for Dr. Houston. One is, it sounds like you want to consider organizing us, really.
Yes.
And so that begins to conflict with some of the laws we have, which are antitrust laws.
So
And so I wanted to ask you whether you thought this out. The second question has to do with could you expound how this would work with direct primary care and Uber docs?
So thank you for that question. So when I first thought about this idea, I actually spent 3 months talking to federal antitrust attorneys about all the antitrust laws and what do they mean and what do they not mean. The bottom line is that we're just not allowed to collude to price fix. That's it. We have all the other rights of any other American. We have freedom of speech, we have freedom of assembly. This is a space for us to assemble digitally. This is a space for us to collaborate and convene on anything that we want aside from fixing the price of the care that we give. When we talk about lobbying efforts, right now you pay $487 to your national or regional medical association and you hope that they are serving your interests and that money, and you hope that money is going towards what you want, but you're really not sure, and who's, kind of salaries are they getting and what kind of vacations are they taking and da-da-da. Well, imagine if you could direct $8 a month towards one law or one bill that you felt was extremely important for your practice or for your patient base. And you knew that money in a decentralized, cryptographically secure way was going directly towards that effort because the code is what dictates that. That's the kind of future I'm trying to build. Of course, we need community, we need a network effect, we need enough people to adopt the idea that this is a possibility, or else it's not valuable. If we have 6 doctors on the platform, which we have more than that already, that's not going to work. So we need a critical mass of 5,000 to break even is the number that we've come up with when we've crunched the numbers.
Okay, last burning question.
I have a question to all of the panelists. I feel like over the course of the weekend, we've spoken about a lot of broad systemic issues in our healthcare system, including access to health, including burnout, costs. And I feel like a lot of the solutions shared over this weekend have been very focused, precise solutions, such as a device or a technology or one model of clinic that could increase access. But my question is, when EMS came into execution, there were lots of different companies that created different EMS systems, and today we have all of these different systems but no integrated solution. So my question to you is, given the complexities and the interconnectedness and the socio-political factors of the issues driving these flaws in our healthcare system, how do we create solutions that aren't popcorn style, lots of solutions? How do we integrate solutions? How do we get buy-in from insurance companies and government so that we can intentionally, collaborate and create one cohesive solution, perhaps going forward, that would incorporate a lot of the ideas that we've shared over this weekend?
My answer is empower the physicians, because we are the keepers of the patient's care. If you notice, everybody's being hit up all the time by pharmaceutical companies and device companies. They're trying to get us to use their stuff, to promote their stuff, blah, blah, blah. That in and of itself should just set a light bulb off that we're the ones that have the power. So we just need to assert that power.
I guess as a Canadian, I see the advantages of single-payer system. And I mean universal access.
Take the 16 people out of the equation that are about pay and get it down to the simplest doctor-patient relationship. You said it best, where it's really just almost that simple. I'm not saying the insurance companies are bad or that they're going to be a dinosaur. They're going to be around a long, long time. But if we have 500,000 patients now that are doing a sidestep from that, the number is going to look like 5 million with the momentum that we have. And we're looking at a future where the doctor wins, the patient wins, the employer wins. That's really what we're talking about, is a holistic solution. And until they all win together, and that's the future I'm living in right now, we don't solve any problems.
I say empower the patient, let them let them be in control of their own healthcare dollar, give them a transparent and give them an easy access, and just kind of restore the old-fashioned kind of fee-for-service model combined with a new technology, because we're going forward, not backward.
I'm going to join UberDoc.
I think in terms of burnout, I think it really comes down to incentivization. Healthcare systems are incentivized to work their doctors to the bone. Medical schools and residency programs are incentivized to push them harder and not to help them in any way. So I think it's about demanding accountability. And transparency. Imagine if you could know before you worked for a company how many physicians were burnt out compared to another, or if you're going to go to medical school or residency, how many people were burnt out versus others. That allows for accountability that really drives that change.
Awesome. Thanks, everybody. Great discussion.